Dr. Shah is a pediatric neurologist and epileptologist here with us in Louisiana, and he is the section chief at Our Lady of the Lake Children's Health. So I'm going to go ahead and stop sharing this slide so that Dr. Shah can share his.
Perfect. Great. So thank you so much for the introduction, Amanda, and thanks Epilepsy Alliance of Louisiana and Epilepsy Alliance of America for this invitation. Give me just 1 second. I'm making sure that my presentation is seen appropriately. Perfect. So are you guys able to see my screen? Just making sure.
Yes, we are. Dr. Shah, I don't know if it's looking different for you, but Zoom seems to have made an update since the last time we presented, but we can see everything.
Awesome. So let me move to the next slide. So just to start beginning, I want to touch base on two main topics here. One is accommodations and the second is rescue, because these are the two most important things in epilepsy that are challenging at times and very important to understand so that we can better manage epilepsy overall. So when we think of epilepsy, seizures are the first thing that comes to our mind. But as this slide shows, epilepsy is much more than the seizure. Children with epilepsy often face wide range of challenges. For example, around 20 to 50% of the kids with epilepsy have attention deficit hyperactivity disorder. 20 to 30% of the kids with epilepsy have autism. Developmental delays are also very common. Anxiety and mood disorders are extremely common with epilepsy. So as you see, it's the tip of the iceberg. That brings to our next slide, why we need accommodations. So based on these factors, based on these comorbidities, I would like to tell my patients that epilepsy is an umbrella term where seizures is one of the side effect of epilepsy, but there are several other things which goes along with epilepsy, which is when you have seizures, it can affect multiple parts of your brain. For example, if it affects the part of the brain which affects your memory centers, which is hippocampus, you can have memory issues. You can have struggle with retaining information or recalling what you have learned in school. Second is if it affects the frontal part of the brain, which is mostly involved in planning, organization, problem-solving skills. So if that part of the brain is affected, then you can get issues in those particular skills. So that's the reason why accommodation becomes really important. It's not just it becomes essential, not just helpful, but it's very essential to get some accommodations when you have epilepsy. So diving deeper into accommodations, it can affect social, it can affect academic, and it can affect other specific academic difficulties that you can get with epilepsy. So firstly, let's talk about social consequences. Children with epilepsy often struggle with fear of negative perception from peers. This fear can lead to difficulties making new friends, which can in turn lead to emotional problems in the school, including mental health issues. And over the time, these challenges can erode child's self-esteem and making it even harder for them to engage socially and participate fully in school activities. Next, talking about academic impacts, seizure along with their side effects, especially with this anti-seizure medication at high doses. For example, if the child is on Depakote or topiramate, those are on high dose of seizure medications, can affect a lot of side effects. For example, sleepiness, lethargy, tiredness, memory issues. So those are important things to keep in mind when we think about accommodations. Furthermore, the level of understanding and expectation from the teachers can greatly influence how well these students can perform academically. And lastly, we must consider specific academic difficulties. Some kids can just struggle with mathematics because some of the focal seizures affect that part of the brain which controls your area of the brain which impacts learning, especially mathematics or spelling or reading and comprehension and word recognition. So having said that, what we can do in school to improve their management strategies. So first and foremost, encourage participation, include students in all the activities and avoid unnecessary restrictions that might limit their involvement. Provide clear factual information about the epilepsy and foster empathy among peers to understand their seizures and reduce the stigma. Other thing we can do is empower students, involve students in discussion and give them leadership roles to boost their confidence. Peer support is extremely important. Buddy systems and encourage cooperative learning to ensure consistent peer support. And last but not the least, with breakthrough seizures, the kids can have absence in the school. So you have to allow flexible participation when they return. And this something which we can put under school accommodation. And this, I always emphasize our patients and their families to discuss with their providers to make sure that they include in their either in their IEP or in their 504 plan or additional letter from the doctors, which can help getting these accommodations in their in the school. Next is academic strategies. So talking about academic strategies, individualized instructions, which we can develop personalized learning plans, including seizure action plans that Rachel discussed. Classroom accommodations are extremely important, where there can be simplified instructions can be used. Flexible assessment, child should be given extended period of time for the assignments. They should be allowed more breaks during the test to reduce the cognitive strain if they are suffering for significant learning issues from epilepsy. And last but not the least, utilize memory aids, break task into smaller steps, regularly review key concept to help their retain information and focus. So these strategies ensures that the students with epilepsy can succeed academically while managing their unique challenges. So now I would like to switch the gears and talk about some definitions to understand why we use rescue therapy and how we use rescue therapy. So I want to give you an analogy to understand this particular concept. So epileptiform discharges are discharges that we see when we do the EEG on the kids who have epilepsy, where we see some sparks. And think of these sparks as a brief flicker or flame in the forest, which are momentary, which are small, and they don't catch fire, but they tell us that this particular person is at high risk of having seizures by looking at their EEG, by looking at their background activity. Now, if these sparks gets more and more, then it kind of gets into a campfire where it suddenly flares up and spreads, and it becomes a seizure, which lasts for less than 3 minutes. And it can happen once in a while. We call it as a breakthrough seizure. However, if the child gets 2 or more seizures, we call it as epilepsy, because those kids are at high risk of having seizures. And there are several triggers which can actually make their seizures more often, which we'll discuss in our next slides. And last not the least, status epilepticus is a massive uncontrollable blaze where your seizures keep ongoing more than 5 minutes and doesn't stop, and you will require rescue medication. So why it's important to discuss rescue medication is because those kids who have seizures more than 5 minutes can sometimes can have brain damage, or can have issues with your respiration, or can have issues with your cardiac system. That's the reason it's extremely important to discuss about rescue therapy. So what is rescue therapy? This is the therapy which we use it for to stop the seizures. Either it's cluster seizures, the seizures which happens back to back to back, or the prolonged seizures, or status epilepticus, which are seizures more than 5 minutes. It's used to prevent seizure emergency, and the rescue medication generally do not replace routine medications to treat the seizures. So person has to take regular medications if they have epilepsy. Rescue medications are just on the top of that to stop their seizures if it's prolonged. Rescue medications are as needed medications. They are created to be used by in school, outside clinic, or ER, or in the hospital. Currently, we have 3 FDA approved rescue medication in children to help control their seizures prolonged seizures. So when do we use rescue medications? So as we discussed, if they happen back to back, if they are prolonged, or if they are going into more than 5 minutes, which is status epilepticus, or sometimes at high risk time when we know that this kid has some risk factors. For example, if the kid is having fevers, sometimes we use rescue therapy as a bridge therapy to make sure that they don't develop seizures. So this is a controversial topic about cluster seizures because various people use this different definition. But to me, if the child is having more than usual seizures back to back, those are known as cluster seizures. Either it can be more than 3 seizures in 24 hours, or it can be more than 2 seizures in 24 hours, or it can be more than maybe 2 seizures in 6 hours. So there are acute, repetitive bouts of seizures. May have sometimes the warning signs. Some kids may feel that their seizures are going to come. They may feel a little dizzy. They may feel a little tired. They may feel some tingling and numbness in their extremities. So they may have some warning signs before they get seizures. But sometimes, most of the time, they may not. And in between, important thing to understand is that in between cluster seizures, the child can come back to their normal self. Unlike status epilepticus, where they don't come to their normal self. So again, there are status epilepticus are two different types. One is convulsive and second is non-convulsive. Convulsive type of epileptic status epilepticus is seizures which continues for more than 5 minutes. And they are having tonic-clonic seizures, or they are having stiffening seizures, or they are having seizures with one side body jerking movements, or one-sided stiffening, or facial twitching. So there are several different types, and the non-convulsive ones are actually difficult sometimes to understand because they may not do anything. They may just be staring in the space, or they may not be responsive for more than 5 minutes. And in those cases, sometimes we may require to do some more investigations to find out if they are having non-convulsive status epilepticus or not. So why do we need rescue therapy? So we just discussed about this, but again, just to repeat, seizure cluster can sometimes progress into the longer seizures. Repeated seizures can have very high morbidity, can cause injuries, can also sometimes cause mortalities if it's not controlled. Can have higher rates of emergency department visits. So we want to prevent that, and hospitalizations. That's why important to use rescue therapy. And patient and caregivers experience negative quality of life if the child keeps having prolonged seizures. Who all are at high risk of having cluster prolonged seizures or status epilepticus? So first of all, those kids who have difficult to control seizures, for example, if they need 2 seizure medications or more than 2 seizure medications, those are drug-resistant epilepsies. Epileptic encephalopathies, for example, the child has severe developmental delays, or Lennox-Gastaut syndrome or Dravet syndrome. Those are difficult to treat seizures. Multifocal epilepsy, that means the seizures are coming from different parts of your brain. If you have a history of brain infections like meningitis and encephalitis, traumatic brain injury, if the child had hypoxia at the birth or some trauma at the birth, that increases your risk of having prolonged seizures. And we'll talk in detail about seizure triggers and higher seizure frequency. So if the child was diagnosed initially and they had more seizures initially, then and at early age, those kids are at high risk of having cluster seizures or prolonged status epilepticus. So what are seizure triggers? Very important to keep in mind, especially when we start school, because sometimes in teenagers and older kids, school stress, homework, sleep deprivation is one of the biggest trigger for seizures. Illness, both with and without fever, can trigger seizures. Flashing bright light that Rachel discussed early on. Drug use of cocaine and other recreational medications, recreational drugs can trigger seizures. Stress, both physical and mental stress, can trigger seizures. Anxiety is one of the common cause of seizure trigger. A lot of girls around the time of puberty or after puberty and adolescence, they get more seizures around the time of their period. So very important to recognize that. Dehydration, not enough fluids, especially in the summers, especially when they're playing out in hot sun, can trigger their seizures. Obviously, missed medication would cause you to have more seizures, and head injury puts you at high risk. That's the reason why initially we discussed about those sports activities where you have to wear proper gears to make sure that you don't get head injury, because on the top of epilepsy, if you get head injury, you have a high risk of having prolonged seizures or status epilepticus. So what are the medications that are approved for a rescue? So currently FDA approved medications: diazepam rectal gel, midazolam nasal spray, diazepam nasal spray, and some of the off-label are buccal midazolam, clonazepam, and VNS, which is vagus nerve stimulator. So what will make your rescue medication ideal? So think about, if you take something orally, it takes time to go into your system. It has to go to your esophagus, then it has to go to your stomach, then it has to go to your intestine, and then it gets absorbed in the body. So that those are not ideal because it will take up to 60 minutes to reach your body. So what we need is either rectal or intranasal or intravenous route to help stop the seizures if they are lasting for more than 3 to 5 minutes. Because they are fast acting. In fact, the intranasal are faster acting, which within less than 3 minutes, it starts acting and helps stop seizures. Even the rectal takes 3 to 5 minutes. Intravenous, yes, those are ideal, but we can't use it in a school setting because it's dangerous to use intravenous unless and until you are in hospital or emergency room. So which one to choose? So right now we have total 3 options. So diazepam rectal gel. So this is approved for kids 2 years and above. And we can repeat one dose in 4 to 12 hours. So if they had one seizure, and then if that does not stop their status epilepticus, you can use another dose to help stop their seizures. What are the pros? It helps in it's easy to dose. It is very long. It's used since many years. Very rapidly absorbed, and can be given in conscious and unconscious patients. The only problem with this is that, especially in the older kids, it's social implications. People may not like deliver rectal medication, especially in the school settings. That's where we have diazepam, which is a nasal spray. Unfortunately, it's only approved for 6 years and above. There are several studies going on right now for kids 6 years and below, but right now it's 6 years and above. It's a very easy to use, and we'll discuss in detail about that. Again, same thing, you can repeat the dose one more time in 4 to 12 hours if the seizures are still ongoing. Yeah, there are no particular disadvantage of this. You just have to make sure that the child is having open nasal passage, but otherwise it's very easy and safe to use. So talking about rectal diastat, as you see on this particular screen, it is a injection syringe like this, and it should show this green line here, which shows that green ready band label. And the dose window is displayed here. So make sure that what's written on your seizure action plan is matching your dose display window here. Make sure that you store it at around 25 degrees, especially here in southern part, Louisiana. If you keep it in the vehicle, it can sometimes get deactivated because the temperatures are in 90s and hundreds. So make sure that you keep it below 80 degrees. How to administer? Very easy. Put the person on their side where they can't fall. Get the medicine, get syringe, and make sure that the pin is attached to the cap, and then push up the thumb and pull to remove the cap. And after that, lubricate the rectal tip with a lubricating jelly, and turn the person on the side facing you, and then bend upper leg forward to expose the rectum, and then separate the buttocks to expose the rectum, and gently insert the syringe tip into the rectum to administer this. Then you count 3, 1, 2, 3, loudly for 3 seconds. And within 3 seconds, gently pushing a plunger until it stops, until the whole dose is given. And again, same thing, slowly count 3 before removing the syringe, and then that's it. And then wait and watch. Within a few minutes, the seizure should stop, less than few minutes though. The next is Valtoco nasal spray. This is one of the easiest thing to do. You have to open the blister pack, remove the nasal spray, and hold the nasal spray device. And then once you put it in the nose, then you insert the tip of the nozzle into the one nostril until your fingers on the either side of the nozzle are against the bottom of the nose, and then administer it. Uh, and it takes less than 3 seconds to completely administer the full nasal spray. So similar to Valtoco, which is nasal diazepam, we have nasal midazolam, which is also approved for kids who are 12 years and above. It's exactly similar like Valtoco. It only comes in one dose, so it's easy to dose for the patients who are about 12 years of age. Um, Sometimes we do experience rectal diazepam shortage. So you can discuss with your provider about clonazepam. Clonazepam wafers are something also which we can use if we don't have other medications available. The clonazepam wafers, those are dissolvable pills that you can put it in the mouth. You use your dry hands to put this particular oral dissolving tablet in the mouth between the cheek and the teeth. And make sure you use the other side, because sometimes with the seizure, as you know, there's a lot of salivation and frothing. So try to use the other side where the froth is less, and so that it easily gets absorbed in your system. So again, Epilepsy Alliance of America has lots of videos in English and Spanish to understand how to administer all these rescue medications. So just to conclude, discuss with your healthcare provider about school safety. And again, remember, epilepsy is more than just a seizure. As we discussed, ADHD, learning issues, anxiety, stress, those are all can be associated with epilepsy. Make sure you get your seizure action plan. If your provider um, uh, is busy, make sure you get your seizure action plan and make sure you get it signed from your providers whenever you go and see your provider. Don't wait for your school to begin. Make sure that you have seizure action plan always ready with you all the time. And again, make sure that you have rescue medication available at different places. Like, let's say if your child is at 3 different places, lives in father's house and or mother's house or in school. So make sure you have 3 kits available. So yeah, that's what I have for today. Thank you for listening and joining.
Thank you so much, Dr. Shah. And I'm really glad you mentioned trying to get your seizure action plan done early. I know for us in Louisiana, school has already started. But I was talking to some of the other neurologists who were saying that it could take them up to a week or so to get these seizure action plans back to families because of the number that they get at the beginning of the year. So it may be a good idea to go ahead and put it on your calendar for, June or July for next year to send in that request a little earlier.